Welcome. My name is Dr. Akshay Jain. I'm an endocrinologist based in Vancouver, Canada, and I'm one of the columnists for the Sugar Beet column at Medscape. I'm super excited to share with you the top learnings that I got from the ADA 2022 conference. Just like every year, this year too, ADA had a lot of feature-packed information. And I wanted to discuss what I feel is the most clinically relevant or clinically impactful aspects that we need to know both right now as well as a little bit into the future. So without much further ado, let's get right into this. The most important game-changing information that came out recently, I feel, was the ADA-EASD joint statement on the management of hyperglycemia in type 2 diabetes. Personally, I feel that this completely changes the way we have been looking at diabetes. We are no longer glucose-centric, but in fact, we have a more holistic and a patient-centric way of approaching type 2 diabetes management. What the current consensus guideline recommends is, among other things, language matters significantly. It's very important that we move away from negative connotations and we stop using derogatory terms like diabetics or an obese individual. In fact, we should be using terms like person with diabetes. Also, something that was very refreshing was the focus on social determinants of health. The consensus guideline statement suggests that it's really important while managing diabetes that we address social determinants of health. And this is really important for having a holistic management of type 2 diabetes. The very important aspect about this guideline statement is that they are having a very patient-centric focus here. And among other things, they suggest that we should be looking at the personal aspects of the patient, including but not limited to their weight, their A1C, their age, frailty, access to care, among other things. Also, by that same yardstick, it's really important that we individualize care, use individualized targets. Also very crucial is that we utilize shared decision-making, including the patient and his or her family members. At the same time, it's important that we utilize SMART goals, so goals that are specific, measurable, achievable, realistic, and time-sensitive. This becomes really important when we are managing diabetes. And then we move forward to implementation of these goals, constantly reviewing and reassessing and giving the patient support whenever needed. A very interesting part of this guideline statement is that we have moved away from being glucose-centric. So what the guideline statement now suggests is that we give equal importance to glycemic control, as well as weight management, reduction of cardiovascular risk factors, and improvement of cardiovascular renal outcomes. So in a sense, for glycemic management, we want to use medications that have the most efficacy without the risk of hypoglycemia. Weight management has come into the forefront with these consensus guideline statements, and it is suggested that we should be trying to help patients with obesity and diabetes help reduce their weight, going to the root part of diabetes. Also, we want to reduce cardiovascular risk. So blood pressure control, cholesterol control, all of this becomes really important. And then finally, of course, cardiovascular and renal reduction of events. So this was the ADA-EASD consensus guideline statements. And personally, I feel this is really changing the outlook of management of diabetes. This is something that we need to start incorporating in our clinics right away and will have possibly the best outcomes that we can achieve. Second very interesting session that I attended talked about the Recolar study. So this was by Dr. Van Raalte and his group, and a very interesting study where they looked at 24 patients. This was a 4-arm crossover study. And the question that they seek to address was, we know that ACE inhibitors and ARBs, as well as SGLT2 inhibitors individually, help with kidney protection in those with diabetes. But what happens when we use the two combined together? So essentially, they looked at patients who were in a 4-group crossover study. So the first group was empagliflozin only, the second group losartan only, third group, empagliflozin plus losartan, and then the fourth group was placebo patients. And what they saw was empagliflozin only helped with blood pressure reduction of about 8.5 millimeters of mercury systolic. Losartan only had a blood pressure reduction of about 12 millimeters mercury systolic, and combining the two together, the blood pressure reduction was about 15 millimeters of mercury. More importantly, what was seen in this study was that in individuals where we are worried about glomerular hyperfiltration, combination of these two medications helps with efferent vasodilatation. So essentially, it reduces renovascular resistance. And because of this, we can potentially have even better long-term kidney protection outcomes. So in this study, it was seen that the GFR drop with empagliflozin group was about 7 points. That with losartan was also 7. And then combining the two together has a GFR reduction of about 10.5, which essentially shows we are reducing that increased pressure at the level of the glomerulus, thereby leading to better kidney outcomes. A third study that I wanted to talk to you about, which will possibly change a lot of the management, the way it's being done at the inpatient setting, will be the use of continuous glucose monitoring in an inpatient setting. So this was a study by Dr. Ilias Panikis and his group out of Emory. And essentially what they did was they took about 180 patients and divided them into two groups. Group number one got point of care capillary blood glucose testing, the same that's being done usually standard of care across the world. And a second group got Dexcom G6 CGM. These are non-critically ill patients that are admitted to the hospital and who are on insulin for management of their type 2 diabetes. What was seen was in the Dexcom G6 group, the CGM group, we saw similar mean daily glucose levels. We saw similar total insulin being required. We saw similar time in range and time below range. But very interesting to note is that in those individuals that have at least one episode of hypoglycemia while they're in the hospital, in the Dexcom CGM group, reduction of recurrence of hypoglycemia, blood sugar less than 70 milligrams per deciliter, was reduced by 47% relative risk reduction. And if you look at a threshold of 54 milligrams per deciliter, recurrence of future episodes of hypoglycemia had a relative risk reduction of 63%. Personally, I find that very impactful. Perhaps not everyone may need a CGM right away when they go to the hospital and are admitted while on insulin, but those individuals that have had at least one episode of hypoglycemia in their inpatient stay, those individuals would benefit significantly from going on a Dexcom G6 or other CGMs while they are in the hospital based on the study. Finally, fourth but not the last, I wanted to talk about a very interesting study called the Retune Study that was presented by Dr. Roy Taylor and his group. We all know that results from studies like the DIRECT trial that showed that individuals with obesity or overweight with type 2 diabetes, if they lose a certain amount of weight, then their chances of achieving remission of type 2 diabetes go up significantly. In the Retune study, what they did was they looked at those individuals with normal BMI, essentially those that did not have obesity or overweight, and they saw what are the chances of achieving remission of type 2 diabetes with weight loss. So they essentially enrolled people who had up to 3 cycles of 5% weight loss or more. And these individuals were given 2-week cycles of 800 calorie diets or restrictive 800 calorie diet by meal replacements, plus vegetables that are non-starchy. And it was seen that in those individuals, especially those who had about a 10% weight loss, the chances of achieving remission, which is an A1C less than 6.5% without any diabetes medications on board, the chances of that remission were about 70%, which is very impactful. These are individuals with a mean BMI of 24.8. Also, interestingly, it was seen that there was a significant reduction in the level of pancreatic fat, hepatic fat, triglyceride levels, as well as fasting insulin levels. So I feel that this study further augments the reason why we want to make sure that individuals with type 2 diabetes, where we know that the diabetes could be essentially related to adiposopathy, so increased ectopic fat, if they are able to lose weight, then we can help achieve the targets of remission of type 2 diabetes. These are only 4 of multiple studies that I found very impactful at the ADA this year. As always, please do check in with the Sugar Beat column, and we'll continue to keep you updated with what's the latest and greatest from a clinically relevant point of view in the world of diabetes and obesity. Take care. Thanks.